here. You go ahead and turn on your cameras. All righty. So everyone should have watched the content video. Let me clear out some of the stuff that's popping up on the screen. Make sure that you sign in on the chat. I have my gloves on for it is absolutely freezing in the building here. So for those of you who are at home. Alrighty, so let's go ahead and get started. So to start off, we're gonna kind of go through a little recap of the content that you probably watched, hopefully, and in its entirety. So this is how our perfusion classes will go. Basically, what I'll be doing is giving you the content videos that are already on there, and instead of me doing what I did on the content on Zoom, we'll actually use the time for you to apply it, because this is where you'll be tested and as far as clinical too. So let's start off with a little recap of what you watched. So what is heart failure? Can anyone tell me?
The inability of the heart to meet the oxygen needs of the body.
Yeah, well, basically, we're unable to perfuse the body. We cannot provide adequate cardiac output, correct? Okay, so what do we mean by cardiac output?
It's the amount of blood pumped from the left side of the heart.
Yeah, it's basically the amount of blood that is actually leaving the heart and perfusing the rest of the body, correct? What is it made of? What makes up our cardiac output?
Stroke
What
volume and
establishes
heart rate.
it?
Stroke volume.
Yeah.
Right, stroke volume, so it's amount of volume, right? And what three factors influence our stroke volume?
Preload, contractility, and afterload.
Preload.
Yes, preload, afterload, and contractility. I'm turning up the speaker in here because I'm having a hard time hearing y'all. Okay, so it's preload, afterload, and contractility kind of determines what our stroke volume will be, right? As far as stroke volume, you know, when we have those three parameters, we're looking at those three parameters. We can look at it as basically preload of what's coming back up to the heart, correct? So that's the amount of volume that's coming up. Your afterload is what the heart actually has to pump against. How much resistance does it have in the arterial system? And then contractility is basically how well does it pump, correct? How well does it contract, expand, and then contract back? So patients in heart failure, do you think that they have a pretty good contractility?
No.
No, most of them don't, okay? So what else is the other factor that influences our cardiac output?
Heart rate.
Heart rate, exactly. Yeah. So between the heart rate and our stroke volume, that is going to help, you know, to establish how much our body is actually going to produce, okay? So we already talked about the factors that influence stroke volume, right? What's the difference between preload and afterload?
Preload is the venous return?
Yeah, basically it's the venous return. And what's the afterload?
What the heart pumps out to the body.
Yeah, it's that systemic vascular resistance that the heart has to pump against, okay? So if that is basically our basis for hemodynamics, and what you're going to learn when you reach level 4 is that we essentially have preload and afterload on both sides of the heart. but we will discuss, you'll learn more about that when you get to 4th level, when you're looking at hemodynamic monitoring and measurements. But for the purposes of this class, we're going to just look at preload as the amount of blood coming back up to the heart or the venous return. And our afterload is going to be basically what the heart has to pump against, okay, or that resistance. So if a patient has a high arterial blood pressure, do you think that increases the afterload?
Yes.
Yes, very much so. What if a patient has high blood pressure and they also have a lot of volume on board, creating that higher pressure? Do you think that increases afterload?
Yeah.
Yes.
All right. And what if a patient has a lot of vasoconstriction that's going on in their arterial system? Do you think that's going to increase your afterload as well?
Yes.
Okay, good. All right. So when we look at our medication management, we're focusing on our goals of treatment are going to be to decrease our preload, decrease our afterload, and improve contractility. Okay. So these are all of the main focus of what we look at when we're treating heart failure. Okay. So what types of failure do we have? What are the types of failure? What's that?
Left side or right side?
Well,
Like
that can
failure?
be on either side, but when we're talking about failure, we can have a pump problem or a fill problem, right?
Yeah, so systolic, diastolic, and mixed, right?
Exactly, right? So we can have systolic, which is what? Is that our pump problem or our fill problem?
Pump problem.
It's a pump problem, okay? That means that we're not contracting. We're not contracting well at all. So how do we measure the contractility or how well we have as far as our systolic function?
The ejection fraction.
Ejection fraction.
Right, and what is our normal EF?
Above 55, right?
Yeah, so all of us sitting here, we are sitting at greater than 55% as far as our EF. Okay, so when we talk about systolic failure, that means that we are having a pump problem. When we talk about diastolic failure, what's the problem there?
Fill.
Yeah, it's a fill problem, okay? That means usually with diastolic failure, the heart is so stiff and it's been replaced by scar tissue that it cannot relax enough to fill, okay? So when we talk about our measurement of our systolic function and that's being an EF, what exactly is the EF measuring?
I guess the strength at which the left ventricle is pumping out that blood, right?
It does give us the strength, but basically what it is, it's the percentage of blood that's actually in that left ventricle and how much actually gets ejected, okay? So that gives us an idea of what that contractility is, all right? We know with diastolic failure, it can't fill, right? It can't relax enough to fill. And so basically we have a diminished amount going into the left ventricle. So if we are truly in diastolic failure only, what do you think that EF is going to look like?
Normal, right?
Yeah. Is there any reason why we would have an abnormal EF? It's not when we have a fill problem, we can't get enough blood in there. That diminishes our cardiac output, but we have an effective pump. So you have patients who can be in systolic failure, which is the most common. We can have patients in diastolic failure, or we can have a patient with both types of failure, okay? And which one do you think is going to have a more severe prognosis?
Mixed.
Yes, mixed, definitely. They can't pump and they can't fill. So they have a poor EF and their heart is so stiff that it cannot relax enough to get an adequate amount of blood. And then the blood that gets in there, it's diminished and it can't pump it out. Okay, good. All right. What about, you guys mentioned earlier as far as heart failure, left-sided, right-sided, right? Can we have heart failure on one side of the heart or both?
Yes.
Yes.
Yeah, most definitely, right? So if a patient only has left-sided failure, what do you think you would anticipate as far as symptoms?
Fluid
Think
buildup?
back to,
Like
think back to your
respiratory?
diagram.
Respiratory.
Respiratory symptoms for sure, right? Now, can it back up further and fail the right heart?
Yes.
Definitely. What kind of symptoms would be specific? I can't even talk anymore. I talked for 2 hours in the classroom and I only had 2 cups of coffee. I think I need more. So what symptoms are specific to right-sided failure?
Ascites, edema.
Edema.
Yeah, so it's all of your systemic symptoms, right? You can have JVD, which is what? Jugular venous distension. Right. We can have JVD. We can have all those systemic symptoms, edema, right? We can have backup into our portal system. We can have backup into our lower extremities. Just very, very common systemic symptoms. So when you have a patient who has both left and a right-sided failure, would they have both symptoms, both sets?
Yes.
Definitely. So they're going to have the lung issues and they're going to have the systemic issues. Okay. So let's talk about what does the body do to compensate when it doesn't have enough cardiac output?
It pumps a little harder.
What does the body do? Someone said it pumps a little bit harder. It more or less, we have our basic sympathetic nervous system that kicks in, right? Because all the body really knows is that it's not getting enough perfusion. So what it's going to do, it's going to be like, hey, I'm not getting enough cardiac output here. The first thing it's going to do, it's going to increase your heart rate. Basics of sympathetic nervous system, heart rate and vasoconstriction, right? Do we need a big floppy rubber band heart sitting there with an increased heart rate?
No.
Not at all. We don't want it. Is it going to work efficiently? Is it going to work more efficiently? It's not a healthy heart. A healthy heart, you increase the heart rate, it's going to increase that volume to get it around. You see, the body is just completely confused because all the body knows is that it's not getting enough cardiac output. So it's going to increase the heart rate. And what happens is that we're making a big floppy rubber band heart work harder, increase its oxygen demands, and it's really not going to improve because it doesn't realize that the heart is the problem. Okay. So we're going to have an increased heart rate, which we don't want. It's going to increase the oxygen demands. And what you're going to learn in Perfusion 2 is that in Perfusion 2, the majority of our patients in heart failure, they came about it basically because they had heart damage from a heart attack. They had ischemic heart damage. They had a heart attack, and that is replaced by scar tissue. Scar tissue is now in the heart. It can't contract. It can't relax. Okay, so this is where we see our problems from. So if you have a big floppy rubber band heart that cannot contract well as it is, and then we just increase the heart rate, and more than likely they had a history of narrowed arteries that fed the oxygen to it, do you think that's a good thing? It's increasing the demands, right? It's increasing the oxygen need, and it's not going to improve the cardiac output. It's just going to put more workload on the heart. Okay, so that's what we see. So we see the heart rate, we see the vasoconstriction. What do you think that vasoconstriction does to our afterload?
It increases
Makes it more.
Yeah, it increases it tremendously. Okay, we have our A system is set loose. So basically what the body is saying, I'm not getting perfused, my cardiac output is poor. So what it's going to do, it's going to go ahead and increase that vasoconstriction. It's going to make it harder. It's more narrow. The pressures are going to go up. So initially your pressures may have been a little low, like your blood pressure, and then it actually is going to increase due to the vasoconstriction. That vasoconstriction is also going to set off a neuroendocrine response by our bodies. Okay, so what are the two things that it's going to release in order to try to improve the volume to get it back up to the heart? Because the body thinks it's just not getting enough. So it's going to do everything it can to increase volume going back up to the heart, when the actual problem is that we just have a big floppy rubber band heart that is not working well. Okay, so it's kind of a vicious cycle. and we're battling our own compensation. So what are the two neuroendocrine factors that we're going to see? What's going to get let loose? I see someone said ADH and aldosterone in the chat, right? So we know antidiuretic hormone, what is that going to do? Is that going to increase our volume? Yeah, very much so. Okay. And what about I can't talk. Aldosterone. What is that going to do?
Retain the sodium.
It's going to retain the sodium, and we know with sodium, what follows sodium?
Water.
Water, right? Do we want these patients, they're chronically going to hold on to their sodium, right? And it's going to hold on to water because their body is always trying to compensate, okay? Which is one of the reasons why we have them in the hospital setting and at home. What type of diet do we normally have them on?
Low sodium.
Low sodium, okay? These are all compensation factors that your body's going to try to kick in to improve cardiac output. So we're vasoconstricting everywhere. That vasoconstriction leads to the release of the hormones, ADH and aldosterone. So now we're holding on the fluid. The kidneys are not, they reduce their urinary output. We're holding on to sodium. We're sending all that fluid back up to a big floppy rubber band heart that just really doesn't work well. So what does that do to our preload?
Decreases it.
It increases it, right? So the bottom line is that we are now going to try to go ahead and decrease that preload and decrease the afterload and improve contractility. But you can see that the body's going to vasoconstrict and it increases that afterload. It's going to send all that volume up, which increases our preload. So that's where you're going to see our medications are going to come into play. What happens next? What's another stage of compensation that the body does? It increases the heart rate, vasoconstricts, holds on the fluid. Now what?
It'll shunt the blood from to the vital organs away from like the kidneys.
Yeah, it's shunting. That's part of that vasoconstriction. But now the heart's also going to enlarge, right? To accommodate all that fluid. And it's going to accommodate in a normal, healthy heart. It's going to get bigger because a normal, healthy heart is going to get big and stretch and then contract nicely. Does this happen on this heart? On a big rubber band floppy heart? No, it just gets bigger. And then over time, it stays like that, right? And when it stays like that, then what we have is hypertrophy, okay? So it stiffens and it stays big. So usually we see that in patients as they progress in their disease in more advanced stages. So our overall goal here, as far as treating heart failure, because it's chronic, right? There is no reversing it. There's no cure. Our overall goal is to keep patients from progressing into more and more severe stages to where their heart is less effective, okay? So how we control it is by controlling the compensation, okay? We control the compensation with the goal of decreasing preload, decreasing afterload, and improving contractility, okay? So any questions with that? None. I'm gonna go ahead and share my screen. We're gonna go through a scenario and then I have some questions at the end. All right. All right, if you don't hear something, just let me know and we can repeat it because we like to interact, and sometimes students are talking over one another. So if you don't hear it or you have a question, just interrupt me. Okay, I'm gonna go to my slideshow. All righty. So any questions, other questions with the content that you guys reviewed? No questions? All righty. So this is the scenario. All right, so you arrive for shift change on the telemetry unit. The off-going RN reports the following. 106B, that's the room number, Mr. Williams, 65-year-old male. He just arrived from the ER. He's admitted with the diagnosis of heart failure exacerbation. I haven't had a chance to assess him or look at his chart. All I really know is that he's awake and alert with a 20 gauge to his left AC. Do you think you guys are going to get those types of reports in the hospital setting? All the time.
Yes.
Okay. So you quickly glance at his chart and you note that the H&P states history of left and right-sided systolic failure. So knowing this is his diagnosis, what should be going off as far as what are you going to consider as the possible things that you might see on this patient?
Edema, respiratory.
Yeah, we might see a
JVT.
combination of both of those systems. We could have lung involvement and we can definitely have systemic involvement. Is every patient going to have every single symptom that we go through? No. Okay,
No.
but it's your job to know and understand what it is that you should be looking for. Okay, and when it tells us in the chart systolic failure, what do we know? What does that tell us?
Pump problem.
It's a pump problem, right? So we expect to have a EF, right? We expect to possibly have a poor EF, and we always want to look at our ejection fractions as where they were previously. These patients are admitted frequently and they're readmitted constantly. This is the biggest reason that patients are readmitted over the age of 65. It is something that has to be managed at home and managed closely. And if they don't manage it, then they end up in the hospital in exacerbation. So usually we can look at the last time that they were here, what was their EFs, what did their chest x-ray look like? Is the heart any bigger? So they'll look at all these factors. They'll also usually do an echocardiogram, which will measure that patient's EF. We can also measure the EF in the cath lab as well. Okay. So let's look at this. These are your other patients. Okay. You have a 58-year-old female with, she's status post PTCA. So PTCA is what you're going to learn about in Perfusion 2. This is when someone has chest pain or has a heart attack and we bring them into the cath lab and we do a percutaneous transluminal coronary angiogram. Yes, it's very long. So that's why we just abbreviate it as PTCA. So they go in the cath lab and usually with they do an angioplasty once they get in the vessel. And if they see that there's a blockage, they'll balloon it and then they'll open and put a stent in to leave it there. Okay. From there, so they had a stent placed to the right coronary artery and they have DC orders. The other patient, 78-year-old male with a history of bradycardia. What is bradycardia?
Decreased
heart rate.
heart rate.
Yeah, it's a low heart rate. Okay. And what does a pacemaker do?
It shocks the heart to
Keeps
pump
the heart rate steady.
for the SA
If
node
you
replacement.
Yeah, what ends up happening, you'll see patients on your telemetry units, they're there for pacemaker placements. And what happens is that these patients usually have a problem within the conduction of their heart. Remember we talked about in the content video how we need electrical activity to create a good mechanical action. So they usually have a problem. They may have a blockage within that electrical system. And it's a blockage in the conduction. So sometimes what we'll see is that they have a low heart rate or it's something that may vary. So the pacemakers are usually put in and they're set to come on and help pace the heart from an electrical standpoint once they reach a certain heart rate, okay? So sometimes you may or may not see them paced, essentially. So when we say see them paced, what are we looking for? Is that something that we can hear? How do we know if a patient is paced?
Telemetry.
Yeah, on a telemetry strip or an EKG, when they actually perform it, they'll see little pacer spikes, okay? So this patient had one put in. Do you think he's relatively stable now?
Yeah.
I would say so. Let's look at your other patient, 62-year-old male with an ischemic stroke 3 days ago, given TPA in the ER, no residual deficits, and he's NPO for a cerebral angiogram. So we're going to learn about this in Perfusion 2 as well, strokes, okay? An ischemic stroke is basically where we have a loss of blood flow or a blockage within that area, okay? TPA is a clot busting medication, okay? And that is our gold standard therapy for stroke patients. It goes in and eats away clots. So normally it's very normal for when a patient comes in and they have a stroke, and if we successfully give them TPA, we can revascularize that part of the brain. And this patient has no residual deficits, which is great. That means that there's no problems, there's no weakness, there's no paralysis, there's no bleed, no other issues, no swallowing issues. And what we usually do is wait a few days to go in and look at the arteries in their brain to see if there's anything that they need to do to fix them. But being that he got TPA, they usually have to wait. So the last one is a 64-year-old male with severe peripheral arterial disease. We're going to learn about this in Perfusion 3. He has his pulse in his lower extremity, in his right lower extremity, is only, you can only access it per Doppler. And he just called him a call light, and he was requesting pain medicine, and he was claiming that he's having a worsening sensation, okay? So arterial disease is basically we have limited perfusion because we have narrowed arteries, okay? So when you look at these patients, in addition to Mr. Williams that just came up from the ER, who would you go and assess first?
The 64-year-old male.
Yeah, so when we're looking at priorities, who are you going to go see first? We're looking at who's in the most distress, okay? We can see that he just calls. We know that he has diminished blood flow to his right lower extremity, and we know that our concern for this patient is that he could potentially lose blood flow. So usually if they're calling up requesting pain medicine, and then if they're claiming worsening sensation, I'm concerned that this patient may have lost their pulse, okay? So that's going to be my first one. Who would you assess next?
Probably a patient with the ischemic stroke.
So we have a patient with an ischemic stroke, but he was given initial treatment and he has no residual deficits, and he's going to go for a test basically to check his arteries.
The patient with bradycardia.
I would do it with the brace with bradycardia, 78-year-old male.
But he has a history of bradycardia. It doesn't say that he's actively with bradycardia, right? What about Mr. Williams?
Yeah, I was going to say him, because shouldn't you want to assess a patient that is new to the floor that you haven't
Yes,
seen?
right. So he just came up from the ER, right? And so no one has really assessed him. You got that report. So that's going to be your next person that you're going to go to. You're always going to go hit the one that's in distress, and then you'll go to that next one, because we know that he's acute, or otherwise he wouldn't have been admitted, right?
Right.
All right. So good. So who would you see last?
The patient getting ready for discharge.
Yeah, definitely. You know, and your patient, more than likely, after I saw Mr. Williams, I would go and see my ischemic stroke patient, simply because they're waiting to go to a procedure, and I would probably make sure that everything was prepared prior to them going. Okay. So any questions with that? And you're going to see the language that we're using with the next gen model and the clinical judgment. You see where we talk about, you know, analyzing cues, you know, prioritizing. It's really just a nursing process relabeled. So don't let that get you too bothered. So assessment and analyzing cues are the same. And so whenever we prioritize, we're looking at who's in the most distress, who are we going to see first, what would we do first, okay? And in testing, not only here, but for NCLEX as well, whenever you see a question that's asking you for priority, you should start thinking airway, breathing, circulation, safety in one of those categories, okay? And even if you don't understand what's in the question, evaluate the options. If your options, one of them is oxygen and the other one is bowel movement, which one do you think is going to take priority?
Oxygen.
Oxygen.
Exactly, okay?
Oxygen.
So we're going to look at that, and I have questions. And then during Perfusion 3, the second hour, we go through a lot of questions, kind of reviewing the content and helping you guys apply it. All right. That's the biggest thing, is for you to be able to apply the information. All right. So based on what we already know and what you guys watched in your content, what do you think when we talk about problems or prioritizing? They call it in the clinical judgment model, prioritizing hypotheses. But in the nursing process, it's still basically identifying your nursing diagnoses. So when you think about concepts and nursing diagnoses, What are the main problems that you anticipate to see with a patient who's in heart failure that you just got?
Decreased cardiac
Respiratory.
output, impaired gas exchange, decreased cardiac output, and one more.
What's the other one? What's causing that gas exchange issue?
Fluid excess,
Fluid retention?
Yeah, fluid retention, right? So, and this is the three main problems that we're seeing with these patients. So when we think about, you should always study your exemplars as if, what if I get this patient on my unit? What am I supposed to do with them? What are the orders I'm going to anticipate? What's the worst thing that can happen to them? And when we talk about the main tenets of this problem, it's a cardiac output, and it's a fluid volume overload that leads to that gas exchange issue. So these are the three things that we're talking about as the main problems. And these are the three things that we're going to look at when we get into, when we go in to do our focus assessment. So everyone should have had clinicals by now, right? So when you go into your clinicals, you're now not doing your prolonged 45-minute assessment that you learned last semester, right? That detailed everything. We're shrinking it down to a basic head to toe, and then you're going to focus it based on the potential problems that you know that this patient may have, right? What are they here for? So we know going into Mr. Williams' room that we're looking for perfusion problems, fluid volume overload, and we're looking for gas exchange issues, okay? So with that head to toe, this is our focus, okay? So let's start off with neuro. When you are going through and doing your head to toe and you start off with your neuro, what do you think, what are some things that you might find on this patient, on Mr. Williams?
Confused, loss of memory, change of mental status.
Yes, he can have all of those. And remember, a patient who is confused, it may not be, whenever you have a patient that has any slight change in mentation, whether or not they don't know where they are, or they don't know what city they're in, or, you have to repeatedly tell them things, or they starting to pick at their IVs, or, sometimes as it progresses, they take off their gown. Patients love to take off their gowns, don't they? For those of you that work in the hospital. And usually whenever we see this change, it's always going to be one of two problems. It's going to be a perfusion problem and or an oxygenation problem, okay? And we know with heart failure that it's likely a combo of both, right? Because we know that the body's goal is to vasoconstrict and shunt everything to our two main organs, right? Our brain and our heart. But it doesn't mean that it's enough. And we also know that when they're in fluid volume overload, we're going to have a decrease in their oxygenation, their gas exchange. So you're going to see a lot of this in our patients, right? They may be restless, they may be confused. Sometimes when they're restless or confused, they may even be a little combative, argumentative, that kind of thing. You'll see that as well, okay? Where are we going now in our head to toe assessment? So we're starting with neuro, and where are we going?
The chest.
Neck and chest.
We're going to go to the chest, and one of the first things that we're going to do is look at respiratory, right? What might we anticipate respiratory wise?
Orthopnea.
Orthopnea, right? So what is orthopnea? Can someone tell me that?
They have to sit up to breathe.
Difficulty breathing while lying down.
Yeah, these patients, you can't lay them back, okay? When they're in acute exacerbation, heavy fluid volume overload, you're not going to be able to lay them back. They need to sit up. And a lot of times this is how we know in the outpatient setting that they're running into issues, because they may have to increase to where when they arrive to your ER and you're triaging them and they say, oh, I can't even sleep in my bed. I'm sleeping in my recliner. I have to sit straight up. Okay. They have difficulty. It's all that fluid and the pressure and so forth. So they have a lot of issues. So we see, they're very short of breath. They can be short of breath at rest, okay, or exertion. And which one do you think is worse?
Rest.
At rest.
At rest, right? I mean, if they're not doing anything and they're still short of breath, we know that that's pretty severe. They may be tachypnic. They may have an increased respiratory rate using all those accessory muscles. They may have that frothy blood-tinged sputum. And is that a concern?
Yes.
Yeah, it's very much a concern because that means that we could be moving into pulmonary edema where we're not performing that gas exchange. So we have to really get that fluid off, support them from a respiratory status. So these patients may need high flow oxygen, they may need CPAP, they may need to be put on vapotherm. And then if they go into respiratory failure from there, then those patients get intubated and put on a ventilator. So we want to prevent that from happening. What do you think their breath sounds sound like?
Crackles, rhonchi.
Yeah, and is there a difference between crackles and rhonchi?
Yes.
Yes.
Yeah, so if in a fluid volume, I'm trying to pull up my chat too. Can y'all see that chat when I pull it up?
No, ma'am.
No.
Okay, good. I just didn't want it to block anything for you guys. Okay. So someone had asked earlier, what is TPA? TPA is the medication that we give to mainly the stroke patients, and it blocks or it eats up any clots that are blocking off arteries. Okay. But our bilateral breath sounds, usually our rhonchi is more of our upper airway, with crackles or our lower airway. With crackles, it's always from a fluid volume overload. Okay. And how do we treat that? Can we just go in and suction them out?
You got a diarrhea?
No.
Diuretics.
We can only diurese them. Our rhonchi, which is usually more upper airway, those are the ones, the sounds that we hear where maybe an older patient has a diminished, cough reflex, and you listen and you're like, can you take a cough? Can you cough and see if it clears? Those patients are ones that you might have to go with a yanker and kind of help suction out the back of their throat. We can't do that with crackles. Crackles is truly a problem where we have to go in and diurese our patients, okay? So you're really gonna hear more of your crackles, and what do they sound like?
Fine
Like
crackles,
Rice Krispie treats.
Rice Krispie treats, yeah.
Yes, it literally sounds like you're pouring milk over Rice Krispies, okay? That snap, crackle, pop, and that's usually more of your fine crackles. Your coarse crackles are a little bit louder and have a little bit more of a, a louder, more wet sound that you'll hear, okay? So, and remember, there are no coarse breath sounds, okay? These are just little pet peeves of mine that you'll hear. Sometimes you'll get reported or you'll see it documented and someone will document coarse breath sounds. There's only coarse or fine crackles. There is no coarse breath sounds, okay? So, and remember, it's just important that you guys always understand how to document correctly, because when are people going to read your notes? Do you
And
think they
there's a
do it for
problem.
fun? Do you think they do it for fun on the night shift? Like, oh, let me see what Taryn wrote. I like the way she documents, right? No, they're only going to read it when something happens or something goes wrong. So you always want to make sure that you document from the covering your assets perspective, right? Where you document showing that you understand what the priority is with this patient and that you have assessed it. And if there was a problem with it, then you have done something about it. Okay. All righty. So where are we going to now?
I was going to ask, can you explain again why you couldn't use suction for a patient with crackles? I didn't quite get why.
Because crackles are a fluid volume overload problem. So the only thing that we can do to fix a fluid volume overload is to diurese them. They're in the lower part of the airway usually, and even if they build up and they're in the upper parts of the lungs, it's just a severe problem. We can't go in, even if a patient's on a ventilator, we can't go in and just suction it out. We have to diurese them. It's a fluid volume overload problem. Alrighty. Oh no. Okay, it's starting to work now. So cardiovascular wise, we know that we're going to probably see some backup into the systemic. So we'll see that JVD. They may have some chest pain. And why do you think they might have chest pain?
Pressure.
So think about it too. Remember, we talked about how the majority of our patients, I gotta move this around so I can see. You guys can't see it, but I can. Remember, we talked about a lot of these patients are in heart failure because they had a previous heart attack. And so remember, the heart is working harder when they're in exacerbation. They have a diminished blood flow to their heart. So that's going to result in angina or chest pain sometimes. They may be tachycardic. What do you think I mean by that they may be irregular? Why would their heart rate be irregular? Why do you think that is?
Maybe because the heart isn't contracting as well, which would affect the afterload.
Yeah, well, remember, it's not contracting very well. And we know that when a heart is kind of big and dilates, it can mess up the conduction and so forth. So a lot of our patients in heart failure end up with an arrhythmia, and one in particular.
Atrial
AFib.
fibrillation.
AFib, right? And AFib, it's not something that we can, you can't, all you would hear with someone that's in atrial fibrillation is that you're going to hear that it's an irregular beat, and you'll palpate it. You can feel it by the PMI. You can usually feel it in their radial pulse, okay? And remember, what happens with AFib is that you have atria that's just sitting there fibrillating. And so it has, in that conduction cycle that we have, and remember, we talked about it in that content video, you have to have good electrical activity to create the mechanical activity. So when that electrical activity is thrown off, the atria just sits there and fibrillates, okay? And so it has nothing, the ventricles really don't have any guide, so they kind of fire off indiscriminately because they're not following the regular electrical activity of the atria than the ventricles beating. So when that happens, it creates the ventricles, your big QRS complexes are just firing kind of indiscriminately. And so you have an irregular rate, right? What was our concern with a patient who is in AFib? What's the concern?
They can formate like thrombus, embolisms, and stroke.
Yeah, they can clot, because remember, blood flow, blood that's just sitting there, what happens when blood just sits? It clots, right? So depending on what side of the heart it's on, it could end up in the lungs, it could end up out of the left side of the heart and go up into the brain and cause a stroke. So what medication would you anticipate if a patient is in AFib? In chronic AFib, what would they need to be on?
Anticoagulant.
Anticoagulants, right? We need to make sure that we keep them nice and anticoagulated until we can get that atrial fibrillation fixed, okay? They have ablation procedures now that they do in the EP labs where they can go in and they can zap certain cells that they think are creating the atrial fibrillation. We have some medications that we can cardiovert with, and then we can also, we've actually tried to shock patients. They'll check in, they'll undergo anesthesia, and we'll literally shock them to try to get them into a regular rhythm also. So these are the different aspects or treatments that they try to do, just because of the chronic problems of long-term anticoagulants. If they're not taking their medications, they can end up with a stroke. So that's why you see this, okay? What about upper extremities? What do you think it's going to look like on a patient who got admitted? Do you think they're going to be hypertensive or hypotensive? And let me pull up my chat too, because I know some of y'all, oh, my chat disappeared. Oh, here it is. Let me go back, because I know some of you guys are responding in the chat. Okay. So what might you see? Do you think he's going to have high blood pressure or low blood pressure?
I have
Wow.
hypo to hyper.
Yeah, it could be either one, right? It just depends on where you are in your compensation. We know that if a heart is failing and the cardiac output is low, that the blood pressure is more than likely going to be low too, right? But once that body kicks in all that compensation, then you're going to see vasoconstriction, retention of fluid, then you're going to be hypertensive usually. You think they're going to be kind of cool to touch as far as their upper extremities?
Yes.
Yeah, because we're vasoconstricting, we're shunting away. You think they may be edematous?
Yes.
Yeah, and when we talk about edema, that's truly second spacing, right? We have some patients that have so much fluid volume retention that they third space. And what is third spacing?
When it's forced into an area it's not supposed to be.
Yes, and the only two areas that are actually third spacing, and you'll hear that a lot in the healthcare arena. Like you'll be getting a report and the patient's, head to toe edema, and they're like, oh yeah, he's third spacing all over the place. No, not really. Just because they're edematous is not third spacing. Third spacing is truly when it's forced into an area that we cannot manipulate back out through diureses or albumin or anything like that, through fluid therapy. So the only two places that we can do that is in the pleural space, which is one of the complications that we see. Remember pleural effusion? So we have so much fluid buildup in the lungs that it seeps out into that pleural space on a patient. So do you think that can impair their breathing even further?
Yes.
Yeah.
Yeah, because they're not expanding their lungs. That can put them in respiratory distress. So they'll come in and we can actually remove it. We call that a thoracentesis, or the doctor removes it, right? And then it also happens when we have back up into our systemic and it goes into that portal and it forces it into our abdominal area, and we call that ascites. And the same thing, I cannot give furosemide to treat ascites. It has to be removed physically, and that's what we call a paracentesis when it comes out of the abdominal area, okay? What do you think their perfusion assessment looks like in their upper extremities? You think the pulses are nice and strong? What about the cap refill?
No, they're irregular, and capillary
Sluggish.
refill is sluggish.
Yeah, cap refill is more than likely going to be sluggish. You're going to have probably weak pulses. They may or may not be irregular. It depends on if the patient's in AFib or not. Okay. They're going to have diminished sensation. They may have diminished strength, because it's just kind of like sitting on your foot, right? You sit on your foot and you lose blood flow. And so, you know, your sensation's not really there. So that's what we might see with some of our patients. Okay. I'm trying to remove my chat. Oh, this thing is just not. There we go. All right. All right. What about GIGU? What would you anticipate? Remember, we're moving in a head to toe direction of doing our assessment, right? What do you think their bowel sounds may sound like?
Diminished.
They're going to be diminished, right? Because remember, I go back to the bear in the woods scenario when we talk about the sympathetic nervous system. I can remember when I was in school, that is how it was taught to us. And it was like, what are you going to do if you walk along and a bear, you know, just stands up in front of you in the woods, right? You know, your heart rate's going to go up, you know, all your fight or flight kicks in. Well, your body doesn't consider your abdominal area as one of your main organs, you know, so it's going to shunt away from there. You're not going to have time to eat when you see the bear in the woods, correct? Right? Your GI system isn't going to be working. You're not going to have all your peristalsis and everything else, okay? So definitely diminished bowel sounds. What do you think about urinary output? What might you see on this patient?
Decrease.
Yeah, definitely. Because remember, I call the kidneys the sacrificial organs, okay? They're very important, and I call them, they're the master chemists of the body. However, anytime you have low perfusion, whether or not it's from a traumatic accident, surgery, heart failure, shock, anything, your kidneys, we don't perfuse the kidneys, the body shunts away, and we're going to have a decreased urinary output. So we're not going to, it's going to be very minimal. It's going to be, you know, it might be what you do get might be dark or concentrated looking. And remember, a patient in heart failure is got the ADH going, and so they're not really urinating as it is. They're holding on to all their fluid. Okay. All right. And I mentioned earlier with your abdominal tenderness, why do you think they would have abdominal tenderness, and where specifically?
By the
The
liver.
liver.
Yeah.
Yep, in your right upper quadrant. Okay. What do you think your lower extremity assessment is going to look like?
A lot like your upper extremities.
Yeah, it's going to be basically the same, because it's still perfusion problems, right? Over time, if they're with chronic heart failure, they may, because they're chronically hypoperfused, you might see a loss of hair and so forth. But normally it's going to look just like your upper extremities. They're probably going to be cool to touch, weak pulses, sluggish capillary refill. More than likely, depending on where they are in their fluid retention, they'll probably be edematous too. Okay. What about your back? What might you find if you turn this patient?
Anasarca.
Anasarca.
Yeah, you might see anascarca. Why do you think skin breakdown may be an issue for these patients?
So they're laying on
they
the
have-
back and
For perfusion.
Well, also they're edematous, a lot of them. So when you get into 3+, 4+ pitting edema, your skin is so stretched at that point that sometimes they break down, they can tear easily. Some of these patients are so stressed as far as their skin, and then in the fluid volume overload, they weep in their extremities. Like they literally have fluid that weeps through their pores. And so that wet skin, it can be, it's very stretched out. It can tear very easily. I mean, I've seen patients where you have to be careful picking up their arms, where when you go to touch them, like just by picking them up, that you could potentially rip their skin. So you have to be very careful. These patients, we usually pad their arms with chuck pads to help absorb it. But what do you think is going to fix that?
getting rid of the fluid.
Diuretic.
Yeah, we got to get the diuretics on board with these patients from a respiratory status, from this issue as well. Okay. All right. So I'm still moving my chat around. So we know that the next part of our assessment is labs, right? If you don't like your labs now, you better learn to love them, because they're your best friend. They're almost as important as it is going in there and actually looking at the patient. And you guys even see that now. I mean, how many of y'all have seen like when healthcare providers come in and they looking at the chart, they're looking at their graphics, they're looking at eyes and nose, they're looking at vitals, they're looking at labs. And when they go in and to look at a patient, they might lift up the cover and maybe, kind of press on their leg and maybe listen to one heart sound area, and that's about it, right? Have you noticed that? Because they're really correlating all their labs and everything else. And this needs to be your friend too. If y'all aren't correlating in clinical, if your instructor isn't, then you make sure that you go home and correlate them. Look them up. Why is this patient's lab abnormal and how does it relate to their condition? All right. So out of these, okay, what do you think would be most pertinent to your patient?
Would it be the digoxin level because it deals with the contractility of the heart?
Yeah, it could be if your patient's on digoxin, right? And why is it so important if you're administering digoxin? Why do you want to check for a level before you do?
Toxicity.
Yeah, toxicity is the problem. Now, are you going to sometimes be giving digoxin to a patient that has no tox level ordered?
No.
Yes.
Oh, yeah. So what do you do?
You got to assess
level before.
potassium.
Check the potassium.
Well, we're going to assess the potassium, but even if the potassium is low,
The signs
is
and
that going to
symptoms.
prevent me from giving it?
Check
No.
the heart rate.
You got to check the signs and symptoms: the nausea and vomiting, the abdominal
Exactly.
pain, and the vision changes, right?
Yeah, we're looking for early signs and symptoms. So if your patient doesn't have a dig level ordered, which that's not all that uncommon, especially if they've been hospitalized for a while, you want to check your charts, look and see, okay, did they ever do a dig level? Nope, they never did one. But maybe the patient was there for something else and they just so happen to be on digoxin as well. So they may not have drawn one. Now, generally, if they come in with heart failure exacerbation, they'll generally draw. But you're looking for any other signs and symptoms. I had a patient in clinical a couple of semesters ago. She was end stage, advanced, probably stage 4 easily, heart failure. She had a pacemaker that was in place, okay? The pacemaker got infected, so they had to take it out. And when that happens, I want to say she needed like 6 to 8 weeks of IV antibiotic therapy. So she was in the facility with a life vest on because she had a pacemaker and a cardio defibrillator. It's combined because when they get really enlarged hearts, they have a risk of sudden arrhythmias, fatal arrhythmias. So they'll usually do an AICD to help not only support them from a pacemaker perspective, but also internally shock them. And so she had to sit hospitalized for 6 to 8 weeks with a life vest on because her AICD came out, and to treat the infection before they could go back in and place a new one, okay? She was also on digoxin, so she was at our facility mainly for the antibiotic therapy and wound care until we could get that AICD put back in, okay? So she was on medications to support. She was also on DIG. So there was no DIG level at that facility, okay? But we came in the following morning after the student took care of him on day 1. Day 2, when we came back, the student comes and reports to me that the patient's vomiting, okay? So we get her something to help control her vomiting. And what do you think we're gonna request at this point? A DIG level. And that morning DIG level, that morning digoxin, do you think we gave it?
No.
We held it until we got a DIG level, and guess what? She was toxic, okay? So we always wanna look for symptoms. If they have a good appetite, there's no other symptoms that indicate toxicity, then go ahead and give it. Even if your potassium is low, remember, a low potassium potentiates DIG toxicity, but if your potassium is low, what should you be given along with the DIG?
Supplements.
Yeah, potassium supplements. Do you think these patients have chronically low potassium?
Yeah, because they're
Apparently,
taking furosemide, right?
That's because all of them are on PO furosemide at home, right? They always are always on it. In the hospital, you're always treating with furosemide. That's the other term is Lasix. And just an FYI on testing, we only use the generic names to make sure that you know them, okay? So furosemide is one of the most effective in fluid volume overload. This is why these patients stay on it. And what you're gonna notice when you're given furosemide, okay, usually when you give that patient that PO pill of Lasix, you're also giving them a PO potassium. So you always need to check their potassium level, okay? Sodium may be important. Really, our sodium could be either high or low. It depends on where we are in our compensation. Are we retaining sodium at this point? And then it may be high initially, but then as the patient just keeps on keeping that volume on board, it's gonna dilute that potassium. I mean, the sodium. We see sodium and hematocrit, they hemoconcentrate or hemodilute based on your patient's fluid volume status. So that's a good way to look at a patient with fluid volume issues. You can evaluate their sodium and their hematocrit as well, okay? I have on there magnesium, and why do you think magnesium is important?
Because it helps potassium.
That's the main reason. We're always battling potassium issues on these patients unless they have kidney problems, okay? Potassium is excreted by the kidneys. So we're always monitoring our BUN and creatinine, because if we see our kidney function, which is BUN creatinine, if those are starting to trend up, then we need to watch our potassium because that's going to be trending up too. So we have to be careful if we notice that a patient is now kind of borderline high. Before I give potassium, I also check their kidney function, because if they've been trending up, then that's something I'm going to have a discussion with, because if I give them that potassium, it might put them over and then they're hyperkalemic, right? And we're always worried with potassium, because why? Potassium too high or too low does what?
Affects the
The
heart.
heart. The heart.
Yeah, it affects the heart by it makes it flaccid, okay? So do we need a big floppy rubber band heart that does not contract well as it is? Do we need it to be even more flaccid and floppy?
No.
No, okay? So that's why we're always monitoring our potassium. It gets depleted with diuretic therapy. And we also have to watch it with low potassium can potentiate that DIG toxicity. Magnesium, the reason why magnesium is important, because we're going to try to make sure that we can't raise a low potassium if our magnesium is low as well, okay? You guys talked about, I'm sure you guys talked about in fluid and electrolytes when it comes to electrolyte sliding scales, right? With electrolyte sliding scales, they're just like our insulin sliding scales. So patients who have chronic issues with maintaining their potassium, or if it's too high, you'll see a sliding scale ordered form where we look at the levels, and that sliding scale always contains both potassium and magnesium. Okay. Where we look and say, oh, his potassium was low this morning. According to the sliding scale, for a potassium of 3.0, I'm going to give him this. Okay. What's some important things that you learned about as far as potassium administration? Do you think you guys taking care of patients in heart failure are going to be administering a lot of potassium? Yes. And patients with a whole ton of problems, potassium is probably the one electrolyte that we're constantly replacing, right? So how do we administer? So we can give it PO. We have pills, we have liquids, we have IVs. The biggest thing is the safety associated with IVs, okay? My first year, I want to say it was only my first year when I graduated. I graduated nursing school in 99. And that year, we still had vials of potassium on the floor. We drew them up and we mixed them. Do you think that was dangerous?
Yes.
Yes.
Yes. I mean, I say the floor, it was in ICU. That was only places that they had it. But in ICU and ER, we mix a lot of our own drugs. Okay. Well, they took that away probably 20 something years ago. And now everything is pre-mixed. Okay. And so how is it normally pre-mixed? And what's the safe administration that we can give potassium? Anybody aware? Did y'all talk about it in fluid and
It
electrolyte?
has to be diluted, right? Because it's lethal. If it's given full.
Yeah,
Usually
you
mix it with
can't
some like
push
normal
it.
saline.
Yeah, it's always diluted and pre-mixed in 100 mils of normal saline. And the most that we can usually give is 10 milliequivalents on the floor per hour, okay? In ICU, we can do 20 milliequivalents per hour. So the safe thing for you to remember is that the safest dose of potassium to give IV, in which most of your hospital's policies follow, it's 10 milliequivalents per hour. Okay, so a common mixture, they might have them supplied as 10 milliequivalents in 100 mils, or it might be 20 milliequivalents. Okay, but you most of your facilities are going to tell you if you're given 20, it's going to have to be over 2 hours, right? So if it's 20 milliequivalents in a 100 mil bag, what are you going to set your pump at?
50 mils an hour.
Well, if it's a 20 milliequivalent bag and you set it at 100 mils an hour, you just sent 20 milliequivalents in an hour.
It wouldn't be,
Be 5.
it wouldn't be in the initial 200.
If you put your rate at 200, then you send it in at a
Mm.
half an hour.
50 milliliters, right?
It should be, if you have 100 mils, if you have 20 milliequivalents of potassium and 100 mils of fluid, you're gonna run that in at 50 mils an hour to achieve it over 2 hours. Okay. All right. So we talked about BUN and creatinine is important for kidney function. What about BNP? What do you think is important about BNP?
That's an indicator for fluid volume, right? And so-
Yeah, so basically it's that stretch on the ventricles. It doesn't really do anything. It's kind of a confirmation of the diagnosis, and kind of like a A1C is to a diabetic. It kind of gives us like where they stand and how can we judge it each time they're readmitted. You know, what's a normal BNP?
Under
Less than 100.
Less than 100, right? Less than 100, you'll see patients come in with BNPs of 1,200, 1,500, 1,800, okay? So it helps us to determine also, a lot of our patients in heart failure may also have COPD, and COPD, especially when you're talking about bronchitis, kind of looks similar when they're exacerbated. They're short of breath, they can't breathe, you know, that they may be swollen. So when they come in, that's a good indicator to tell us if it's a respiratory problem or a heart problem, especially if they have both. All right. So why don't we go ahead, since y'all are home, we're going to take a 5-minute break, and then we'll come back and finish it up, and I have some questions at the end too.
Ms. Leinhardt,
Uh-huh.
I have a question. I know you said that with the potassium is diluted in every 10 that's diluted in 100 mils, or
It may come pre-mixed. It may come pre-mixed at 10 milliequivalents, or 20 milliequivalents. But the thing that you need to know in 100 mils, usually if the provider orders the 10 milliequivalents, or if they order 20, it may just depend on how it's stocked at the facility, but you can see them pre-mixed both ways. The key to remember is that the safest IV administration of potassium is 10 milliequivalents per 1 hour. So if you have 20 milliequivalents in a 100 mil bag and you're you're not in ICU, then it needs to be run over 2 hours.
Gotcha.
So it's a 100 mil bag. It's not an 1,000 mil bag, right? 100.
No, now you can see sometimes you have potassium added to, like it might be D5 half normal with 20 milliequivalents of K. Sometimes you even see 40 milliequivalents of K. But when we're replacing as a rider or as a supplement, we're replacing as giving it as a one-time dose. It's not usually mixed in a 1,000 mil bag.
Got it. Thank you.
And is it usually mixed in D5W or normal saline?
It could be mixed. It could be mixed either way. It just depends on
Okay.
what's ordered for the patient. Sometimes you'll have patients that come in and depending on their sodium, depending on their other things, a lot of your alcoholic patients, they are usually depleted with a lot of things and they may mix up several things in one bag, including potassium. So it depends on the needs of your patient.
Okay, thank you.
All right, so y'all come back in 5 minutes. All right. So hopefully everyone is back. All right. So let's go ahead and finish on this. So any questions so far? I don't see any in the chat. All righty. So out of the following diagnostic tests, what do you think is going to be most pertinent to a patient in heart failure?
ABG.
It could be. It could be if they're in respiratory distress, right? If they're having an oxygenation problem, we might see that. What do you think are the most common tests that you'll see ordered on all of your patients?
EKG.
EKG, right? Chest X-ray. What are we
X-ray.
looking for in a chest X-ray?
Heart size.
Yeah, heart size. It can also tell us what fluid. 12-lead EKG and an echocardiogram. What do you think they're going to tell us with an echocardiogram?
The output?
Fraction.
We're looking
Ejection
at EF, yeah. Echocardiogram, it can kind of sometimes, it can estimate your cardiac output, but it's really looking at your ejection fraction, okay? And that's what we're looking at because our most common problems that we see is the pump problem. It's a systolic failure, okay? And then when we see, and it's most common on the left side, and why do you think that is?
The most common heart failure.
Yeah, but why do you think the left side is most common as far as failure? The left side of the heart.
Because it's where your afterload intercepts at mostly.
Where you what?
Yeah, your afterload, where you get
Exactly, right? Because what does your left side of your heart do? It's constantly pumping against your arterial system. So it's usually the side that's going to fail first, unless your patient has some kind of restrictive lung disease where they have increased pressures in the heart. So that's why the left side of the heart is bigger and it's stronger because it's constantly pumping against your arterial system, which is a higher pressure than the pressures within your lungs, okay? But all of these that you could potentially see ordered on your patients with heart failure. Commonly, they always do a chest X-ray when they come into the ER. They'll do a 12-lead. What do you think we're looking for with the 12-lead?
Arrhythmia, the AFib.
Yeah, if they have any arrhythmias, commonly AFib is the most common with these patients, okay? They do the chest X-ray, they're looking at size and they're looking at fluid. They'll order an echo to help with EF, especially if it's systolic failure. You may have to Doppler pulses on them, depending on, if you can't, and remember, these patients are going to be hypoperfused. So they're going to have those poor perfusion symptoms. So it's not like, oh, I can't feel his pulse, but, oh, his cap's good, his foot is warm, so it must be okay. No, they're going to be mottled looking because they're vasoconstricting and shunting away. They're going to have diminished pulses, sluggish capillary refill. They're going to have cool extremities. So you can't just discount it that you can't feel it. So sometimes you might have to Doppler it. If they have any kind of respiratory issues, especially if their pulse ox is on the low end, they're going to order an ABG. ABGs you'll learn more about when you get to acid base, but basically ABGs are going to measure, it's going to measure certain factors that we look at. And our most concern is always going to be a respiratory acidosis, because if a patient progresses to respiratory acidosis, then normally what ends up happening is that we need to support them. And usually it's on mechanical ventilation. So that's what they're looking for. Anytime a patient has any type of breathing issue and there's a decrease in the pulse ox, they're going to be ordering an ABG. Okay. KUB, that's your kidney, urethra, bladder. It's just basically an abdominal X-ray. So they may do that if the patient has an enlarged liver or ascites. If they're having kidney issues, you might see the renal ultrasound too. Okay. So we know that our priorities are cardiac output, gas exchange, fluid and electrolytes, but what are some other problems you think they may have? when you think about nursing diagnoses or prioritizing your hypotheses?
It's insufficient knowledge.
Yeah, they may have a health maintenance issue, right? They may have a ton of things, a knowledge deficit, activity intolerance, anxiety, breathing pattern, fatigue. There's all these things, skin integrity, tissue perfusion, right? Out of these, what do you think has the highest priority?
Breathing pattern?
Yeah, when we talk about priorities, we're talking about airway, breathing, circulation, safety. So in testing, whether or not it's asking you which patient you're going to see first or what intervention, you need to always relate it back to those factors: airway, breathing, circulation, safety. So when you look at this, we can easily see that breathing pattern and tissue perfusion is probably going to be way up higher on our our hierarchy of needs there, right at the top of our pyramid. And what do you think is going to be the least?
Health
Maybe
maintenance.
anxiety?
Activity.
Well, anxiety, do you think that could potentially,
That gives me
Uh,
respiratory.
anxiety can definitely enhance any kind of respiratory issues, right? So on a patient that can't breathe, I put anxiety right up there behind airway, breathing, circulation, safety, because it can make it worse, okay? But when we talk about things that are our lowest priorities, it's going to be something such as our health maintenance and knowledge deficit, because anytime a patient is in distress, is that an opportune time to educate a patient? Not at
No.
all, okay? So we don't want to do that. So that's going to be on our lower priority, okay? We are looking at the things that's going to impact that patient, that can bring the most harm when we're talking about priorities, okay? So let's look at Mr. Williams' vital signs. What's something that may jump out on you?
The mean arterial pressure.
The O2.
Well, the mean arterial pressure, it shows that he's actually perfusing pretty well, right?
Right. Well, yeah.
But look at his blood pressure though. That's because he's vasoconstricting all over the place, right? But what about that heart rate? Is that normal? His pulse?
No.
It's in a normal range, but it says it's regular.
It's irregular, right?
No.
So what does that cue us in
Irregular.
on? What he might be having?
Arrhythmia.
He might be
Arrhythmias.
having an arrhythmia, but that 92 is, yeah, it's within normal limits. But do you want a big floppy rubber band heart sitting at 92?
No.
No.
No, these patients, we usually have them on beta blockers for rate control, and we want to keep them in the low 60s. Some of you cardiologists may even say, write an order where you only hold the beta blocker if they're less than 50. And we see that commonly too. Okay, so we definitely don't want that pulse rate. Respiratory rate, that kind of correlates to, what we're going to probably see in our assessment data, right? What about that pulse ox? Is that concerning to you at all?
Yes.
Yeah, that's a red
Yeah.
flag. So when we talk about something that needs your immediate attention, which one would it be?
The pulse
Pulse ox,
ox.
definitely. So this patient's on 6 liters of O2 per nasal cannula. And remember, we have in clinical, I'm sure you guys will go over respiratory equipment. Some places have regular nasal cannula that only goes up to 5. Other places have high flow nasal cannula. And then you have veni mask and so forth. But 6 liters and they're still only sat in 90%. That's definitely concerning. And that's what's going to get my most immediate attention, right? Especially vital signs. Let's take a look at his assessment. Okay. I gotta move my chat over. So you go in and you assess your patient, okay? And so initial assessment, patient receives sitting upright in bed, awake and alert, oriented to person in place. Pearl 3 millimeters, appears anxious and restless, restless extremity movements at times, O2 6 liters per nasal cannula, SpO2 90%, bilateral breath sounds with coarse crackles and anterior posterior fields, respiratory rate even with increased respiratory effort, dyspnea at rest, S1, S2, and S3 noted at PMI, irregular rate, positive JVD. He's got a 20 gauge PIV to the left AC. It's working. No signs and symptoms of infection. Dressing clean, dry, and intact. Bilateral upper extremities are cool to touch. 1+ radial pulses bilaterally. Cap refill 5 seconds. Full sensation and strength. Abdomen soft and non-tender. Bowel sounds positive ×4. 16 French Foley. It's secured to the leg with 100 mils of dark amber urine. With sediment, bilateral lower extremities cool to touch with 3+ pitting edema, 1+ dorsalis pedis pulses. Say that 3 times real fast, right? Bilaterally, full sensation and strength, TED hose in place to bilateral lower extremities, no skin breakdown noted. So that's your narrative assessment, okay? You need to learn how to write narrative assessments, even if your facility is check boxes, everything's a checklist, because if something goes wrong, it's not, you don't put it in the checklist. It goes on usually a separate form, and usually you need to do a narrative assessment. Okay, and you always want to be able to give a clinical picture and show that you know what you're talking about, right? Because remember, they're not going to read your notes unless something is wrong. Okay. So is there anything that stands out to you as far as this assessment? What do you recognize? Let's start at the top. Because remember, we're going to do head to toe. What do we see in the neuro part?
Anxious, restless.
Yeah, anxious, restless extremity movements. More than likely, although his MAP was 90, he could have pretty good perfusion going to the brain. But if he's in fluid volume overload, then we have an oxygenation problem. Okay. So that's when I say always look at your factors, because it's going to be one or the other, and it could be a combination. His pressure is up, and so he has a good MAP also. So he's probably getting enough to the brain, but it's just probably with all the fluid on board, he's not picking up the oxygen. And we see that also with this SpO2 of 90, okay? Usually your orders are gonna say maintain O2 greater than 95%. So what would you probably wanna do at this point in time? We know our priority is to get the medications on board, but what can you do easy enough with an SpO2 of 90%?
Put a new rebreather mask on?
We would, now he's on 6 liters on a high flow, we can bump it up, but you would increase it. So if you were, if your nasal cannula didn't go any higher, the next step would be a venti mask, because you can go up to like 65%, okay? But your clinical instructors should go over that with you in clinical too, like your oxygen equipment, because remember, respiratory is what respiratory therapists do is everything that we're still responsible for and that we do, okay? So don't ever get it, and you see a lot of new nurses, everyone's like, call respiratory. No, you need to be able to work your vent. You need to be able to give a patient a treatment, because guess what? Respiratory therapists aren't always around, okay? And you're still responsible for doing all that, okay? So even if you don't get a lot of exposure in school, when you're in training, when you're precepting at your job after you graduate, get with the respiratory therapist and go over things, okay? If you feel like you haven't had a good exposure, because you're still responsible, okay? You're responsible to make sure they do it and they do it correctly. For whatever reason, where I worked, and it was at every facility I ever worked at, all of the respiratory therapists smoked. I don't know why, okay? But they did. And so the one that we had 3, because we were supposed to have one for each ICU, because we had 3 ICUs. Well, sometimes only one would be on duty, and that respiratory therapist was responsible for 3 units. So, or you couldn't find anybody, or they were on smoke break. It was just never. So we ended up doing most of it in ICU. And if you're working with vent patients, you need to be able to manage a vent, okay? So let's see. So we see that, so here we're gonna bump up his oxygen, right? And we definitely gonna wanna get those with bilateral breath sounds with coarse crackles, definitely getting your Lasix. Now these patients are probably gonna be getting 80, 100 milligrams IV push, okay? So what would you check before you would push 80 to 100 milligrams of furosemide? What would be important to note before you push it?
Potassium levels?
Potassium.
Your potassium, but if your potassium is low, is that going to prevent you from giving it?
No.
No.
No. What would prevent you from giving it? You're about to reduce volume drastically.
Decreased blood pressure.
Right. If for some reason your patient had a decreased blood pressure, you know, if they were earlier on, that would be something that you would communicate and decide between your healthcare provider. But whenever we're given IV Lasix, you always want to make sure that we have an adequate blood pressure, which he does, right? So bilateral breath sounds with coarse crackles. He's going to increase respiratory effort. What about in his cardiovascular part? Do you think that's significant? S1, S2, and S3?
That has a lot to do with the fluid overload, right?
Yeah, that has to do with your fluid volume overload is when you'll see that S3. Okay, so you might see the S3, listen to me. You might hear it, and then you also might hear murmurs. But remember, we're not cardiologists, so we're looking and we're going to note that there's something additional, either an additional heart sound or that we hear, you know, a potential murmur, but we're not going to say, oh, he's got a grade 3 systolic murmur, okay, because you're not a cardiologist. So just keep that in mind. Like if you get report or if you see that in your chart, we're only going to document what we hear. We're not going to diagnose it. All right. So he's got irregular rates. So I'm concerned for AFib. He's got positive JVD, right? So we know that he's all backed up, totally fluid volume overload. His upper extremities and lower extremities, it's obvious that he's got he's got shunting away from his extremities, okay? Because we're low as far as our cardiac output. Let's look at his abdomen. So he doesn't have any tenderness. He's got positive bowel sounds, right? Because we anticipate either positive or hypo. And if we look at our Foley, is that anything significant? So we see he's got low urine output and it's dark amber urine with sediment. So that correlates with everything that we should be seeing, okay? So look at this. He's got 3+ pitting edema in his lower extremities. So what can we do about that?
Dangle the leg.
Yeah, and now is dangling might make his edema a little bit worse?
Yes.
It might. We want to protect his legs because we know that once we start diuresing this patient, we can get that fluid off. We want to protect his skin, protect his legs, but we want to keep the fluid down there because that's keeping our preload low. The last thing we want to do is elevate those legs above the level of the heart because that's going to increase our preload, right? Is there anything on here that is concerning to you as far as maybe something that you would address as you're doing your assessment? We know we're going to increase that oxygen, but anything else that you might do?
Elevate the head of the bed.
Yeah, we're going to want to make sure he's already sitting upright in bed, right? They're not going to let you lay him down.
Can you turn them or?
Yeah,
You
Turn
can
cough,
turn them.
deep breathe.
Yeah, turn, cough, deep breathing, right? Kind of talk to him, calm down the anxiety. What else? Anything on there that could affect your preload?
Those TED holes.
Thank you, right? What do TED hose do? TED
Push it
hose,
back to the heart.
TED
Yeah.
hose are used for patients who generally have vein issues, right? We have faulty valves. We have a backflow of blood. The blood gets down there, but it can't get back up. We call that chronic venous insufficiency. So a lot of times we're putting TED hose to help return the fluid that's in the lower extremities back up to the heart. Or is that the problem with this patient?
No.
He's not swollen because he has chronic venous insufficiency. He's swollen because he has too much fluid on board, and we don't want to bring that back up. It goes against our goals of treatment, which is decreasing preload, decreasing afterload, and improving contractility. So you should always say that to yourself when you're looking at treatments. What is this going to do? Because it's going to fit in one of those 3 categories, okay? So what do you think I would do at this point? I would have taken off.
Remove the TED hose?
Yeah, I'm gonna document all my actions after I do my data. So under my actions, I'm gonna have how I increase the increase the oxygen. Hopefully I went ahead and gave the Lasix by now as ordered, right? I'm gonna, my other action is gonna be, the TED hose removed, MD notified, especially if they were, ordered that way. Sometimes, especially, I always worked in teaching hospitals, which I love. I think those are the best places for you guys to learn. The only problem with teaching hospitals occasionally is that you're working with residents, and what they're doing is a lot of times they're going by clinical guidelines. So it's everything they tell them that they should be doing, but sometimes they don't, not everything is going to fit that patient. Okay. So I would see this a lot in a clinical setting where they would order things where it didn't really make sense. Okay. So you just let them know. I would document everything that I did and then the patient's response, right? You never want to document problems without documenting what did you do to address it and what was the patient's response. Okay. All right. So any questions on that? And yes, you would address the restlessness and the anxiety too on that patient. And I would definitely have that written in there. Okay. So let's look at Mr. Williams' labs. Anything concerning to you guys?
That BMP.
Yeah, that's pretty big, huh? Pretty high. Is there anything that I'm going to do to address that BMP at this time? No, not really.
No.
No, you know what it does? It just confirms everything that I just saw in my assessment, right? So no, there's nothing, but it's a confirmation. We know that they have fluid volume on board, but it's definitely elevated. Okay. Any other labs that jump out at you? Good job on that.
Yeah, hematocrit.
Well, hematocrit, what does that kind of go with? What other lab that's on there would that hematocrit kind of match?
Hemoglobin.
Hemoglobin.
Well, we look at hematocrit and hemoglobin together to determine whether or not a patient's anemic. But remember, when we're talking fluid volume overload, remember hematocrit gets hemodiluted. His hemoglobin is just fine. Okay. So he's not anemic, but definitely that hematocrit is low at 30. Okay. And look at his sodium. That's your other value that gets hemodiluted or hemoconcentrated. So definitely your sodium is hemodiluted. So this just confirms between the hematocrit and the sodium that this patient's in fluid volume overload, right? Anything else concerning on there? Potassium's a little low, right? Depending on more than likely they're on a 3.5 to 5 scale. So we would definitely want to make sure that we're looking for an order for potassium, because what did you just push?
Furosemide.
Exactly, right? And your magnesium, that's all right. Glucose, remember your glucose is always, even in a non-diabetic patient, which he didn't have diabetes in this scenario, but non-diabetic patients will have an increase of glucose. Anytime you're stressed or sick, your glucose elevates, okay? Creatinine, how is that?
That's normal.
Yep, it's good. No other issues that I'm really seeing. What about that INR? Is that a concern?
That's normal as well.
It's normal, but what did we note as his heart rate in our assessment?
90.
Irregular. It was irregular. Right?
It was irregular, right?
Irregular.
So we're going to be a little concerned if this patient is truly an AFib and he's in subtherapeutic range, meaning that he's not really coagulated. In order for him to be in a therapeutic range, he needs to be 2 to 3 on his INR. Okay.
Gotcha.
All right. So basically, I just went ahead and I recopied the assessment, so it's there. But you can kind of go through each one. So what are we going to do neuro-wise? What are our actions? What are our interventions that we're going to do?
Increase the oxygen to neuro. And
yeah, oxygen is definitely going to help that neuro, because we know that he's got a strong MAP. He's getting perfused to his brain, but he's still slightly confused. So, and we know that by getting rid of the fluid, we're going to improve the oxygen, right? So neuro-wise, but when you look at his assessment, definitely increase in his oxygen, making sure that his Lasix is given, you know, and all the checks that we do. All right. What about respiratory wise? Kind of the same thing, huh?
Right.
It's really addressing the fluid volume. And we're going to support them with oxygen, high flow oxygen, even if we have to do vapotherm, CPAP, anything, we are going to support until we can get that fluid off. That's why it's such a high priority to hurry up and get that that Lasix on board, or the furosemide. All right. What about cardiac wise?
Removing the TED hose to prevent that afterload or preload.
Yeah, we remove the TED hose, right? We are going to make sure that we get their medications on board. Now, we saw his heart rate, right? What do you anticipate us giving him for his heart rate?
Anticoagulants.
Well,
Beta blocker.
Beta
Yeah,
blocker. Yeah.
definitely beta blocker. Someone said anticoagulants. Now, the anticoagulants won't affect the heart rate, but it will help prevent any clot formation if they're in AFib, okay? But the only thing that's really going to control our rate, and you're going to see this on our patients all the time, you'll see beta blockers ordered. So this patient, being that he was sitting at 92, they may go ahead and order IV push beta blocker, okay, to ensure that we get that rate down. Because remember, we're not giving them beta blockers to control the vasoconstriction. It helps a little bit, but we're really using those prils, right? Our ACE inhibitors, and our sartans, which is our ARBs, to really help control that intense vasoconstriction. We might even use nitrates on patients to help control the vasoconstriction. So that vasoconstriction is going to help reduce the afterload, like if we block it, and the medications that we give them. And it's also going to, when we vasodilate all over, it kind of leaves that fluid where it is. So that's going to also help with our preload as well. Okay. As far as upper and lower extremities, we anticipate that when the medications kick in and we block the vasoconstriction and we diurese them, that we're going to see an improvement on that as well. We're going to protect them and support them until we can get our medications going. What do you anticipate with your urinary output?
Decrease.
Yeah, more than likely it's going to be decreased, but once you hit them with 80, 100 milligrams of Lasix, what do you think that's going to do?
It's going to increase it.
Yeah, exactly. So you want to make sure, avoiding per urinal, you want to make sure that the urinal is in reach, right? We don't want a patient climbing out the bed trying to reach it. We want to make sure that they understand if it's a female and they don't have a catheter, we want to make sure that they call us and we offer them a bedpan and so forth. Just because, are we going to want these patients up and ambulating? No. And we're not going to want them getting up and going to the bedside commode until their respiratory status improves, okay? If a patient has a Foley in, what do you think you might want to make sure with the Foley?
You've emptied it, or it has enough room.
Keep an eye on it so you don't run into any issues. If we're pulling off a lot of fluid, we don't want it backing up. We don't want the bag, any issues with the bag, with it leaking. There's two people you always want to be your best friend in the hospital, and that's going to be your CNA and housekeeping. You don't want to make either one of them mad. Okay. All right. So those are mainly the things. We should see an improvement on our patient in all of our symptoms, okay? We are kind of talked about the medications that we know that we're likely going to give, right? Just make sure that you understand what are the safety checks. We know that prils and ARBs and vasodilators are going to reduce blood pressure, right? So that's always a risk with orthostatics, right? As far as safety issue, falls. So when you do start to get your patient up, you need to make sure you do it slowly and have them sit before you have them stand. We know with diuretics that we're going to have the same issue because we're reducing volume, right? Beta blockers, we already talked about. What's one of the concerns with when you're introducing a beta blocker? Say this patient wasn't on it, or we were giving them a different beta blocker. What's the concerns with beta blockers that you have to be concerned about?
First dose phenomena.
Yeah, it's either first dose, and I've actually seen it in patients, and it's not all, and it could just be not necessarily first dose. I actually saw it on a patient where he started on it. I think he was on it for 3 or 4 weeks. It was almost a month. And it generally happens with propranolol, because propranolol also works on your receptors within your lungs, and it can cause bronchoconstriction. This guy was on a daily dose of this medication for a month, and then all of a sudden he went into where his lips became swollen, and it started to get progressively worse, and they were able to get him to the hospital in time. He ended up with an emergent tracheotomy, okay? And then he had a trach for about 2 weeks until they could get it off, but he had a severe delayed reaction to propranolol, okay? So there's always a concern with giving a beta blocker on someone that has COPD or asthma or any kind of restrictive airway disease because of the chance for bronchoconstriction, okay? Inotropic agents, we know what's the main one that we give.
Digoxin.
Digoxin that you'll see. We have some other ones that we keep patients on that are usually more infusion therapy that you're going to learn more about when you get to level 4. So we'll just concentrate on this one mainly because of the toxicity that's associated with it. All right. So we know the safety checks and we know what to expect, right? All of these are working in some form or fashion on preload, afterload, or contractility, right? So when you look at that, we know that we're reducing preload and afterload with all of our hypertensive medications, with all of our diuretics, right? That beta blocker is helping to reduce that heart rate, okay, which is going to help improve contractility as well as our inotropic agents, okay? So this is what we're looking for. We're looking for these to work. And so when we reevaluate our patients, we reassess them, we're looking to see those medications kick in, and we should see an improvement of all of our symptoms, okay? All right, and also make sure that you understand what you should be teaching him, right? We know that the patients go home. We don't keep them on fluid restrictions at home, but we do keep them on sodium restrictions, 2 to 3 grams. We want them weighing themselves daily. We want them to take their medicine, because the problem is with these patients is that, you know, they on diuretics daily. So they are going to the bathroom all day long. And then when they're sleeping at night and they're flat, and just because of gravity, their kidneys are better perfused. And so the kidneys start working better. So they're up all night urinating. And so if they're feeling good, they're not short of breath. Sometimes they might skip that Lasix for the day, right? Then they go by their neighbor's house and go eat crawfish, right? With all kinds of sodium. And then where do they end up 3 days later? In your ER because they can't breathe, okay? So this is the things that we want to make sure that we teach them, to monitor their weight, 2 to 3 in a day, 3 to 5 within a week. A lot of our heart failure patients, we have telehealth programs that they're involved in where we're managing them. So just think about that. You guys are going to school online. You could work as an RN online managing heart failure patients, right? So these are some of the things that we want to teach them. We went over some more in the content. So remember, our focus is always going to be that clinical judgment / nursing process. So how do you assess them? What are the priorities? What are you going to do for them? And in those interventions or those actions are going to be your orders. Those are going to be your medications, your medication checks, your labs, all those kind of things. And then what are you going to teach them? So if you concentrate on that, you'll be good. All right. So let's go to a couple of questions and then we'll end it. Let me see. I can do a poll to make this real easy. All right. So y'all can go ahead and put your answer in.
I can't see.
You can't see the poll?
Oh, never mind.
Did everybody click on? Okay, now it's coming up. All right. I still have people answering. All righty. And yes, most of you guys went ahead. Remember, it's going to be number 4. You're measuring the overstretch with a BNP. You're just measuring the volume. An injection fraction, we would only be able to get per Doppler, or an echocardiogram. That's what it is. It's a Doppler of the heart, or it's we get it in the cath lab. Okay. Ischemic events, we're going to talk about that in perfusion 2. That's when we're looking at a troponin that's released when there's damage to the heart. So that when we talk about BNP, we're talking about measure that overstretching. And on differentiating, there's no lab that's going to differentiate left and right-sided failure. Okay. All righty. I'm trying to get to my thing to go to my next question. All right, let's go to that one. And the poll should be there. So we always look at what the question is asking. It's right-sided heart failure and what would be significant for right-sided heart failure, a symptom. Fatigue is going to be for either left or right-sided, right? Shortness of breath is going to be, shortness of breath and crackles are always going to be strictly left side, but edema in the lower extremities would be specific to right-sided failure. Okay, good. I'm going to relaunch it. All right, let's go with this one. It's a little bit more complicated. Okay, good. It looks like everyone pretty much picked the correct answer here. So when you have these chart questions like this, okay, look at what it's asking you. So he's in AFib, the evening nurse. So what does AFib tell you? What should they be on if they're in AFib?
Warfarin, heparin, anticoagulants.
You should be on an anticoagulant, but say you didn't know that. Say you just didn't want to, you didn't listen to this, you weren't interested. And so whenever we have something that we're going to question, we're looking at as a potential danger. So even if you look and you're not sure what they're asking in here, but we're going off of the correct answer is going to be warfarin because the INR was 3.4. And we want to keep that within 2 to 3. But when you're doing test questions, whether or not here or through NCLEX, just look at, so if this is something that we're questioning, that means it could be potentially unsafe. We know that this is just going to stimulate an appetite and peristalsis. We know that this is a stool softener and this reduces cholesterol. So even if you didn't know or you couldn't pick it out, when we're talking about questioning, I mean, are we worried about colace or are we worried about warfarin? Okay.
So which one was the correct answer?
Warfarin.
Warfarin, okay. I don't understand.
So which one is going to warrant immediate attention? Actually, this has 2 parts, so I'm going to end the poll because you can only put one.
The Joxy level.
So when we talk about immediate attention, like what is going to cause the most harm to a patient? and we see the potassium's 3.8 and INR 2.8, and the patient has a sodium of 146. So we know that a serum digoxin of 2.6 is extremely high, okay? So when we talk about which one is gonna warrant immediate action, it's the one that's gonna put the patient in most jeopardy. Which one should you evaluate for trends?
Sodium.
Sodium, I mean, it's 146, right? So, but are we ever going to correct a sodium level on a patient in heart failure? Are we going to do anything about it? The only way we really correct sodium is by giving fluids, correct? And this patient more than likely is going to be on a fluid restriction. And we know that that sodium is going to fluctuate as we diurese them.
How about
What's more concerning to
How
trend?
about the
The
potassium?
potassium level because of the digoxin level? You don't
Yeah,
want the
well, we
toxicity?
definitely, we want to look at and trend his potassium. If he's, you know, slowly going down, or have we been having to add and give him more? Because we want to see where we stand with this, and do we need to increase or whatever. And yeah, and we do have to worry, we're not going to be giving him any ditch at this point, right? More than likely, we're going to have to give him the antidote. And what's the antidote? Digibind is the antidote, okay? So look at this question. I know it's, we're a minute or two afterwards. I think I have maybe one other question. This might be the last. So this is what happens to patients. They come in with one problem and then they develop another one, okay? Not a lot of times you'll see patients come in, we're putting them on anticoagulants, and then what do they get? A GI bleed, right? They have an ulcer, they have something. So then they want to have a GI bleed, and then next thing you know, we have to give them blood, okay? So when you talk about, when you go to question something, we're concerned about it, okay? Is there anything that jumps out to you on these answers that would be concerning, even though you know nothing about PRBCs or giving blood?
Restricting their fluid?
We want to restrict their fluid, right? Because he's in heart failure. We're going to give that Lasix probably in between, right? Because we're giving them, when we're giving them 1,000 mils, do we know how much the PRBCs are? They're anywhere from 350 to 375 per bag. So you're talking about giving 2 units. That's going to total up to almost 800 mils, and he's on 1,000 mil restriction. So this is more concerning right here, is to administer it quickly, right? This patient's not going to be able to handle an influx of volume. So this is just things to think about, because this is what happens with your patients. They snowball. So we're worried that he's decompensating. What is going to require immediate action?
Dyspnea at rest.
Yeah, remember, we're concerned. It's a problem. Airway, breathing, safety. Is a dry, persistent cough going to do anything to anyone? A lot of your heart failure patients have this when they're not in fluid volume overload. Weak peripheral pulses, look, as long as it's there, right? That's just like when, you know, when you say, but did you die, right? As long as it's there. We worry when there's no peripheral pulse. And JVD is something that's there. We're not going to really do anything until we get it, you know, until they get diuresed. So we're always concerned, airway, breathing, circulation. All right. This is actually the last one. So what's the first part of your assessment of your nursing process? And I just gave you the answer.
Assessing why he's not eating it.
Yeah, why he's not eating, what has he been eating? So what would be the right answer?
Number
2.
Check to see if
2,
he's
right?
able.
Look, if he's been at home, do you think they really, I mean, he's in the hospital because he's exacerbated. So more than likely his food isn't 2-gram restricted sodium, right? And we're not going to tell him that it's just important. We need to address the problem. So the correct answer would be 2, because you're assessing, you're evaluating what's worked. All right. So if y'all have any questions, you can put them on the discussion board. That way everyone can see. This is how all of my perfusion classes go. I can easily do the content on Zoom, but I know you guys, we don't have a lot of time for reading. So that is your pre-prep, and it gives you the content, and then we can use class time to go over and really apply this information. And that's what's going to matter, because it matters in testing and it matters when you're caring for patients.
Miss Hart, I can't find the normal